this is part 2 of the lecture on corneal ulcers. In this, our learning objective is to enumerate, describe and discuss types of viral keratitis. Herpes simplex and herpes zoster are the most common types of etiological agents which cause viral keratitis. Herpes simplex virus keratitis, in this the infection can either be primary or recurrent. Primary herpes simplex virus infection can present as blepharoconjunctivitis, follicular conjunctivitis, lid vesicles or as conjunctival dendrites. Recurrent infection happens if the patient is predisposed to some of these factors, and that leads to reactivation of dormant virus that has been sitting in the ganglia. So the causative precipitating factors can include fever, any physical or emotional stress, immunosuppression, minor local trauma, exposure to UV light or cold wind. If the epithelium is involved, then in cases of infectious epithelial keratitis, the causative agent is the live virus, which is there in the epithelium and causes an immune response. In cases with neurotrophic epithelial keratitis, there is an impairment in the corneal nerves or there is a damage to the basement membrane, and sometimes it can also be caused by drug toxicity. In cases of involvement of stroma, when we have immune stromal keratitis, as we use the word immune, there would be an antigen-antibody complex mediated damage. In cases with necrotizing stromal keratitis, we have direct viral invasion which causes necrosis of the stromal tissue. In cases where we will come across endothelium involvement, there will be an immune reaction which is involving the endothelium. So to begin with, we will talk about infectious epithelial keratitis where epithelium is involved. So the first form of this is punctate keratitis, in which we have punctate, stellate, raised whitish opacities which are there because of swollen virus-laden cells. The patient presents with watering, photophobia, irritation and blurring in the vision. So here we see small pinhead-like white opacities, and these opacities are laden with viruses. The patient can also present with dendritic keratitis. In this, we have swollen epithelial cells that enlarge and coalesce to form branching dendrites. These dendrites have terminal bulbs, so they appear slightly elevated from the surface. They can be viewed under a cobalt blue light on a slit lamp after staining the corneal surface with fluorescein. Epithelial sloughing can be seen in the center, and that leads to formation of dendritic ulcer. These dendrites have linear branches, they have raised edges, they contain live virus, they are usually central or paracentral. When we will talk about herpes zoster ophthalmicus, we will be talking about pseudodendrites which are devoid of terminal bulbs and are more peripheral in location. In this, we also have anesthesia in the area of ulcer. So when you check the corneal sensations, the sensations would be diminished. The ulcer is stained with both fluorescein as well as rose bengal. Fluorescein stains the length of the ulcer. The rose bengal dye, since it is slightly irritant in nature, is instilled in the eye after a drop of topical anesthetic agent has been put in the eye. This dye stains devitalized swollen epithelial cells at the ulcer border. Now, this can also go on to progress as a geographical ulcer or can present as a geographical or as a amoeboid keratitis. Now here, the dendrites enlarge to assume amoeboid shape. So initially, we had thin, narrow dendrites. Later, they coalesced to form a dendritic ulcer. And when they coalesce to form a much larger ulcer or they involve a much larger corneal area, they form a geographic ulcer. This also takes up the staining just like a dendritic ulcer. So we have a very large ulcer here, which after staining gives the shape of amoeba, or it is pretty large in its area. Another form of this is neurotrophic epithelial keratitis. This is also known as metaherpetic ulcer. You can get a short note on metaherpetic ulcer because the traits of this ulcer are slightly different from what we have described before. This happens as a chronic post-herpetic corneal inflammation. So the patient has had an herpes infection earlier. Maybe he had a course in which everything was fine, but there was some amount of smoldering infection that was there, and patient later on presents as a neurotrophic ulcer. At this time point, there is no active virus. The causes can be impaired corneal innervation, poor tear film, or if the patient has been chronically using topical antiviral therapy. This ulcer is usually round or oval in shape, as we can see here, and it has thickened and rolled up margins. It takes up reverse staining with rose Bengal stain. So the rose Bengal otherwise was staining the periphery, but here the rose Bengal is staining the neurotrophic ulcer itself. Now this reverse staining characteristic can also be asked as an MCQ question, and otherwise trophic ulcer or metaherpetic ulcer can come as a short note for your exam. It's very important to be able to differentiate neurotrophic ulcer from geographical ulcer. There is always a history of recurrent attacks when we talk about neurotrophic ulcer. In geographic ulcer, they can present for the very first time, or there can be a previous attack. Neurotrophic ulcers have a long duration. They have a long duration of even treatment. As I already mentioned, that they can be also seen in patients who have drug toxicity to long-term use of antiviral therapy. The location of a neurotrophic ulcer is an interpalpebral area, while that of geographical ulcer can vary. Neurotrophic ulcers usually stay constant over a period of time because here the viral activity is not there, as there is no active virus which is causing the damage. Geographical ulcers, on the other hand, can increase or decrease in size depending upon the response to the treatment that the patient is receiving. The margins of a neurotrophic ulcer are shallow and clean, while that of the geographical ulcer are raised by virtue of inflammatory activity. Plus, there is also virus-laden devitalized cells at the margins. Rose Bengal staining, in this the margins are not stained. We have reverse staining in a neurotrophic ulcer, but in a geographical ulcer, as I had already mentioned earlier, we will have stained margins with rose Bengal dye. Antiviral drugs, they worsen neurotrophic ulcer, but they promote resolution in a geographical ulcer, which is an active ulcer in which we have live viruses. That was the epithelial form. Now we come to the involvement of stroma. So herpes simplex virus stromal keratitis can come as a short note, or you can have a long answer question in which you have to address all forms of herpes simplex virus keratitis, which includes its epithelial involvement, stromal involvement, as well as endothelial involvement. So stromal keratitis, it forms about 2% of primary cases and nearly 20 to 50% of recurrent cases. It may occur just as a stromal inflammation, or it may occur as a consequence of epithelial keratitis or endothelitis. Here we will have necrotizing stromal keratitis. So there is a necrotic activity that is happening in the stroma with dense stromal infiltration, and that would be associated eventually with ulceration. Viral replication is happening actively in stromal keratocytes, and there is a severe host inflammatory response to this viral activity that is happening. This can lead to thinning and perforation in no time. This is also associated with prominent vascular activity. So we have conjunctivalization of cornea in a patient who has responded to therapy for stromal keratitis. Now, stromal keratitis can also be immune-mediated stromal keratitis, which is also called as interstitial keratitis. This can come as a short note. Interstitial keratitis is the most common form of stromal keratitis. It's a type 3 immune reaction to the viral antigen, and in this we have deposition of antigen and antibody complexes in stroma. So you can get a question, what type of immune reaction is seen in interstitial keratitis? Type 1, type 2, type 3 or type 4? So the answer is type 3. In interstitial keratitis, there is stromal infiltration, neovascularization, growth of abnormal blood vessels associated with corneal thinning. but the epithelium is intact most of the times, except in cases where stromal involvement is secondary to epithelial involvement. You can also see punctate stromal opacities. Some patients present with an immune ring of Weasley, in which there is a circular deposition of antigen-antibody complexes along with leukocytic infiltration, and this is usually seen in mid-stroma. So in this image, we have an immune ring of Weasley that is formed. Sometimes you can even have a double ring formation. So you can have an MCQ question on immune ring of Weasley. In which form of viral keratitis is immune ring of Weasley seen? So the answer is stromal keratitis. Stromal neovascularization can also happen, which can be sectoral or circumferential. So in this image, we have inferior sector that is having stromal neovascularization. We can also have necrotizing stromal keratitis, which is relatively less common. In this, there is a direct invasion of stroma by the herpes simplex virus. And then we have active viral replication, which results in intense stromal inflammation. This can also occur if steroids are given without antiviral cover. Now, I mentioned in one of the previous slides, MCQ questions in the last lecture, that in which form of keratitis are steroids indicated. Now, it is stromal keratitis, but even in stromal keratitis, we cannot give steroids without the antiviral cover. The clinical features of necrotizing stromal keratitis include corneal necrosis, which is very evident right in the paracentral area of this image. There is ulceration and there is an overlying epithelial defect over this ulcer. It is also associated with uveitis, and thus these patients can have raised intraocular pressure. After stromal involvement comes the endothelium. Herpes simplex virus can involve the endothelium and result in endothelitis. Now, this is a delayed hypersensitivity reaction, hence type 4. So, the question for interstitial keratitis, we had type 3 reaction. For HSV endothelitis, the reaction is type 4. It is a cell-mediated response. So, the patient can either present with disciform keratitis or diffuse endothelitis or linear endothelitis, depending upon the location of keratitic precipitates and presence of edema. Disciform keratitis can also come as a separate short note in the exam. This is the most common form of endothelitis. In this, we see a disc-shaped area of stromal edema overlying few keratitic precipitates without corneal infiltration. These are usually central or paracentral in location with associated trabeculitis and uveitis. Now, whenever we have associated trabeculitis or uveitis, we will have elevation of intraocular pressure. So, in cases with disciform keratitis, anti-glaucoma therapy is given along with the rest of the antiviral agents. There will be edema and keratitic precipitates which are out of proportion to anterior chamber inflammation. So, we can see that we have a paracentral diffuse edema. When we make a slit beam with the slit lamp, we can see the endothelial involvement. Diffuse endothelitis is relatively rare as compared to disciform endothelitis. This also occurs because of an immune reaction against the corneal endothelium. In this, the keratitic precipitates are scattered over the entire cornea with diffuse stromal edema, and there will always be associated iritis, and hence we can expect a rise in intraocular pressure. So in the image here, we see that the almost entire endothelium is involved over a wide area. Linear endothelitis, on the other hand, has a line of keratitic precipitates on the endothelium, which progresses centrally from the limbus. There is edema between the lines of keratitic precipitates and the limbus. So, herpes simplex virus trabeculitis and iridocyclitis, it is a form of recurrent non-granulomatous anterior uveitis, which occurs as a response to immunological reaction to the virus. In this, clinically, we will see circumciliary flush, keratitic precipitates, cells and flare in the aqueous. There would be high intraocular pressure secondary to the clogging of trabecular meshwork. and that can serve as a diagnostic hallmark. Some cases you will see sectoral or patchy iris atrophy. Recurrent episodes have this feature quite commonly, and you can pinpoint the causative agent as herpes simplex virus. And sometimes when the superficial layers of the iris are gone, then the iris blood vessels can even have certain hemorrhages. So iris hemorrhages can also be seen. Usually the diagnosis of ocular herpes simplex is based mainly on the clinical examination because the clinical presentation is quite characteristic. But laboratory investigations may be required in certain atypical cases. So cytology, in which Giemsa staining is done, can be performed in certain cases of necrotizing keratitis. In this, we will see multinucleated giant cells. Viral DNA detection can be done using PCR technique, and here the sample from the tear film or corneal scrapings can be taken. The sample collection must always be done before staining because rose Bengal dye can be toxic to the virus, and the detection of the virus will be difficult if the sample is taken after the rose Bengal staining. Virus isolation can be done by doing viral culture. This provides a definitive diagnosis. The culture inoculation is done with the sample swabs. Typical cytopathic effect is seen in 2 to 4 days, and it can take up to 10 days to get the viral culture report. ELISA can also be done, and it can help to differentiate primary infection from first recurrence. Paired sera are usually tested whenever we are doing this test. The first sample is taken 3 to 4 days after infection, while the second one is taken after 4 weeks. If you find low titers in the first sample and about 4-fold rise in the second sample, then that means the patient is having primary infection. But if you find moderate titers in first sample and then 4-fold titers increase in the second sample, that refers to a recurrence. Antiviral drugs can come as a short note. The commonly used antiviral drugs for viral keratitis include trifluridine, which is given topically. Acyclovir can be given topically as well as orally, and so can be ganciclovir. Valacyclovir and valganciclovir are given orally. So a landmark study, the herpes eye disease study 1, looked at the role of steroids and of oral acyclovir on patients with stromal keratitis. So on patients who were having stromal keratitis but not on steroids, if topical steroids were given along with topical antivirals, it was found that it resulted in faster resolution and fewer failures. On patients who had stromal keratitis and were taking steroids, addition of oral acyclovir along with topical antivirals did not have any apparent benefit. So there was no role of oral acyclovir. Patients with herpes simplex virus iridocyclitis and taking steroids, in them when oral acyclovir was added, there was some amount of benefit that was seen. The next step to this was the herpes eye disease study 2. In this, the herpes simplex virus epithelial keratitis patients were taken, and the role of early oral acyclovir along with topical antivirals in seeing their progression to stromal keratitis and iridocyclitis was evaluated, and it was found that there was no additional benefit of giving early acyclovir drug. When it came about the acyclovir prevention, it was seen that the efficacy of low dose oral acyclovir, that is 400 milligrams given twice a day, in preventing recurrence of ocular herpes simplex virus, there was reduced incidence of epithelial and stromal recurrence by about 40%, and there was 50% reduction in occurrence of more severe infection later. So 12 months of oral antiviral prophylaxis is effective in preventing both epithelial and stromal keratitis recurrence. Role of external factors such as corneal trauma and behavioral factors such as stress and recurrence was also evaluated, and no statistically significant external factors were found that led to recurrence. So the American Academy of Ophthalmology, they gave a treatment guideline for herpes simplex virus keratitis. So in patients with epithelial keratitis, usually topical trifluridine or ganciclovir gel is given, along with oral acyclovir or valcyclovir if needed. In patients with dendritic herpes simplex virus keratitis, topical therapy is given quite frequently and it is tapered as per the response of the patient. Oral acyclovir is given 400 milligrams 5 times a day for 7 to 10 days. When it comes to valcyclovir, the dose is much more convenient and there are lesser adverse effects. It is given 500 milligrams twice a day for 7 to 10 days. Oral famciclovir is given in a dosage of 250 milligrams twice a day for 7 to 10 days. Geographical ulcers, by virtue of their size, require more oral therapy. So, oral acyclovir for geographical ulcers is given 800 milligrams 5 times a day for 2 to 3 weeks. Valcyclovir, if it is given in a dosage of 1 gram 3 times a day for 2 to 3 weeks, while valcyclovir is given 500 milligrams BD for 2 to 3 weeks. For stromal keratitis without ulceration, therapeutic topical steroids are given with prophylactic oral antivirals. Topical prednisolone is given, which is a steroid. It is given 8 times a day with tapering over 10 weeks depending upon the response of the patient, along with oral acyclovir or valcyclovir. If there is ulceration, then we limit the topical steroids along with therapeutic oral antivirals. In endothelial keratitis, we give a therapeutic dose of topical steroids plus therapeutic dose of oral antiviral therapy. Prophylaxis for recurrent herpes simplex virus keratitis includes acyclovir 400 milligrams twice a day or valcyclovir 500 milligrams once a day or famciclovir 250 milligrams twice a day for at least an year. The indications for the same include multiple recurrences, especially of stromal keratitis, recurrent inflammation with scar which is encroaching the optical axis, if there has been more than one episode of herpes simplex virus keratitis with ulceration, if the patient is post-keratoplasty, if the patient is post-operative and had a history of ocular herpes simplex virus keratitis, or if there is a history of ocular herpes simplex virus and the patient is currently on immunosuppressive therapy, then you need to give prophylactic therapy for at least a year. For a neurotrophic ulcer, we need to protect the basement membrane, so we have to stop antiviral therapy. Copious lubrication is given in the form of artificial tears which are preservative free. For non-healing ulcers, a bandage contact lens is applied so that recurrent damage does not happen. In patients who have keratouveitis and associated elevation of intraocular pressure, topical prednisolone is given 6 to 8 times a day and topical cycloplegics are given in all these patients along with lubricant eye drops. If there is an elevation of pressure, then anti-glaucoma drugs are added. Certain patients may require surgical management in the form of either a conjunctival flap and pedicle or amniotic membrane grafting, lateral tarsorrhaphy, or some patients may even need a keratoplasty, which can be full thickness penetrating keratoplasty or just lamellar keratoplasty. The indications for surgical management include necrotizing keratitis, corneal scarring, persistent epithelial defect non-resolving to bandage contact lens therapy, and severe neurotrophic keratitis. Coming to herpes zoster ophthalmicus, it is caused by the varicella zoster virus. The zoster resides within the ophthalmic division of the fifth cranial nerve, and it is quite commonly seen in elderly individuals who are immunocompromised. There is a rash which first begins as a macule and progresses to form either a papular lesion or a vesicle, and then pustules that have dry and crusty appearance can be seen. These, if not treated in time, can even leave prominent scars. The ocular manifestations are uncommon in varicella but common in ophthalmic zoster. Zoster usually begins with some prodromal symptoms. The patient can have a rash, they can have a mild fever and malaise. If the vesicles are present on the side and the tip of the nose, so if this side of the face is involved and the tip of the nose is also involved, then this is called as Hutchinson's sign. This can come as an MCQ question as well. And in this, there is the involvement of external division of the nasociliary branch, and the probability of the involvement of eye is quite high as up to 75%. The pathophysiology of herpes zoster ophthalmicus is that initially there is a primary infection by the virus which remains dormant in the sensory ganglion. Any precipitating factor can lead to reactivation of this viral infection, which will result in replication in the nerve cells and eventually shedding of the virus down the axons to the skin, which is supplied by the ganglion. And the patient will present with inflammation and blisters, and there will be intense pain due to perineuritis caused by the viral. Precipitating factors include physical stress, emotional stress, if the patient is immunosuppressed or immunocompromised, and infections such as tuberculosis. 70% of patients with herpes zoster ophthalmicus, they have ocular involvement in the form of either conjunctivitis, episcleritis, epithelial keratitis, uveitis, stromal keratitis or endothelitis, and out of this conjunctivitis is the most common one. So here in herpes zoster we see pseudodendrites. How they are different from dendrites that we have seen in herpes simplex viruses, that these are smaller in size, they are elevated without central ulceration, they do not have terminal knobs, and they lack the central staining, which is a characteristic feature of herpes simplex virus dendrites. So on top we have dendrite because of the herpes simplex virus, and at the bottom we have the flatter sort of dendrites without terminal bulbs, which is there because of the herpes zoster infection. The complications with VZV or the varicella zoster virus include acute retinal necrosis, which is seen in immunocompetent individuals. In immunocompromised individuals, progressive outer retinal necrosis is seen. Details of these two entities are outside the scope for undergraduate teaching. The patients can also have focal choroiditis, papillitis, which involves swelling of the optic nerve head. They can also have cranial nerve palsies, and third nerve palsy is the most common nerve palsy. They have severe post-herpetic neuralgia, so the pain can last as long as 3 months or even more after an episode of herpes zoster ophthalmicus, and this is commonly seen in elderly individuals who had severe rashes at the time of the attack. Allodynia, which is characteristic non-noxious such as blowing wind, even blowing wind can cause pain in these patients. And the quality of the pain is quite variable. In some, they will report sharp shooting pain, and in the others, they have a burning sensation throughout. So this needs to be addressed because the patient is very uncomfortable. For varicella zoster virus, 800 milligrams acyclovir is given 5 times a day for at least a duration of 10 days, no later than 4 days after the onset of the rash. Oral analgesics need to be given for the pain. Topical antibiotics are given to prevent secondary bacterial infection. Dexamethasone or any other steroid eye drop can be given with antiviral eye ointment to reduce ischemia and fibrotic scarring. Systemic steroids are given if the patient is having progressive proptosis with total third nerve palsy and if there is associated papillitis. Artificial tears are given in abundance. So with this, we come to a few MCQs. The first one is, all of the following occur in herpes zoster keratitis except pseudodendritic keratitis, anterior endothelial keratitis, sclerokeratitis, endothelitis. We have pseudodendrites in herpes zoster, which is a very characteristic trait of this entity. Episcleritis or scleral involvement along with the corneal involvement is known. Endothelitis is also known, but anterior endothelial keratitis is a characteristic trait only of herpes simplex virus. So the answer is anterior endothelial keratitis. The next question is, corneal sensations are diminished in which of the 4 entities? Herpes simplex keratitis, conjunctivitis, fungal infections or marginal keratitis. As we have covered this topic in the initial few slides, we know that there is anesthesia at the base of the ulcer. So the answer is herpes simplex keratitis. And the last question is, topical steroids are contraindicated in a case of viral corneal ulcer for fear of which problem? Secondary glaucoma, cortical cataract, corneal perforation, or secondary viral infection. In secondary glaucoma, topical steroids are helpful because they take care of trabeculitis. Cortical cataract is usually not caused by steroids. Steroids are known to cause posterior subcapsular cataract. Secondary viral infection is not the answer, as in most cases we are giving topical steroids along with coverage of oral antivirals. So the answer is corneal perforation, because steroids, they thin out the cornea further and predispose the eye to corneal perforation. So with this, we come to the end of corneal keratitis. We have covered viral keratitis in this lecture, and in the previous lecture, we covered bacterial and fungal keratitis. I hope you enjoyed this lecture. So with this, thank you very much for your kind attention.